Hi everybody, and welcome to our module on viral hepatitis. There are 5 viruses that cause viral hepatitis, and they're all named by a letter, either A, B, C, D, or E, and all of them are RNA viruses except for hepatitis B, which is a DNA virus. All of these viruses can cause liver inflammation, and some can cause a chronic infection, and chronic infection can potentially lead to cirrhosis or hepatocellular carcinoma. No matter which virus infects the liver, there are some common themes in terms of the acute symptoms and the initial clinical presentation. The first thing to know is that many acute infections are asymptomatic, so some patients will get a chronic infection and not recall ever having had an acute infection from a virus, and that's because the acute or initial exposure was asymptomatic. When people do have symptoms from an acute viral hepatitis, these are usually symptoms of inflammation like fever and malaise. There are also GI symptoms like nausea and vomiting and decreased appetite, which is anorexia. Patients with acute viral hepatitis will have right upper quadrant pain. This is because that's where the liver is located and it's inflamed. They often get jaundice. Jaundice occurs when there are high bilirubin levels in the blood. It's a yellowing of the skin from bilirubin. The liver's job is to excrete bilirubin, and when it's inflamed, it does not do its job, so the bilirubin levels get high. Patients with jaundice often have itching, and that's because bile salts deposit in the skin and they are irritating. They will also have dark urine. When bilirubin levels are high in the plasma, they spill into the urine and make the urine dark. And then finally, people with acute hepatitis have clay-colored stools, and the reason for this is because you need to have normal bilirubin excretion to make your stools dark brown, the color you're used to looking at. Let's talk about that in a little more detail. So the liver conjugates bilirubin and excretes it in the bile. Once it gets to the GI tract, it's converted by bacteria into a substance called urobilinogen, and then urobilinogen is converted into stercobilin, and that's what makes your stool dark brown. If you don't have normal bilirubin excretion from acute viral hepatitis, you will have clay-colored stools, and these are stools that lack that dark brown color. There are some characteristic blood test abnormalities in patients with acute viral hepatitis. The levels of AST and ALT will be increased. These are the liver function tests. These are enzymes that spill into the blood when there's inflammation of the liver. In viral hepatitis, the ALT is usually higher than the AST, and you should contrast this with alcoholic hepatitis. So people that drink alcohol heavily can get an acute hepatitis, but in that setting, the AST gets very high. It's usually much higher than the ALT. In viral hepatitis, the ALT is greater than the AST. The bilirubin level will be elevated in patients with acute viral hepatitis. This is an elevation of the direct bilirubin level. So in the setting of viral hepatitis, the liver can still conjugate bilirubin. That means it can synthesize direct bilirubin, but it can't transport it into the bile, so it backs up and the level gets high in the plasma. Another thing to know about viral hepatitis is that it's one of the many causes of a false positive elevation of the VDRL level. This is a screening test for syphilis, so it will be elevated and abnormal in patients with viral hepatitis, but don't confuse the infection with syphilis. So now let's start talking about the viral hepatitises individually, and we'll start with hepatitis A virus. This virus is a member of the picornavirus family, and you can remember the members of this family by the mnemonic PERCH. P is for poliovirus, E is for echovirus, R is for rhinovirus, C is for Coxsackie, and then H is for hepatitis A. All of these viruses are non-enveloped, and they all have a positive sense single-stranded RNA genome that is linear. They also all have an icosahedral capsid. All of the picornaviruses synthesize one large polypeptide, which then gets cleaved to make multiple viral proteins, and all of these viruses are transmitted fecal-orally, including hepatitis A. The virus is shed in the stool of infected persons, and then uninfected people can get it through personal contact with the stool from an infected person, often from drinking contaminated water that's been exposed to the feces of infected persons, and sometimes from consuming raw seafood. If the seafood was swimming around in contaminated water, it can be carrying the hepatitis A virus. As you can imagine, that makes this virus very common in underdeveloped countries where they have poor hygiene and poor sanitation. So a classic case scenario to know for your boards is a traveler who goes to Mexico or Central or South America. And the virus has an incubation period of 30 days, so someone may develop acute hepatitis symptoms a month after they come back from one of these countries. You can diagnose an acute hepatitis A infection by finding anti-hepatitis A IgM antibodies in a patient who has typical symptoms of acute viral hepatitis. You can diagnose a prior exposure or infection by finding evidence of anti-hepatitis A virus IgG antibodies in the serum. This is a self-limited condition. There's usually no specific therapy. Hepatitis A only causes acute disease. There's no chronic infection. And as I said before, like many of the viral hepatitises, this is often an asymptomatic exposure. So sometimes an antibody panel will show anti-Hep A virus IgG in a person who does not recall ever having had acute hepatitis, and that's because the initial infection or exposure was asymptomatic. There is an inactivated virus vaccine that's available. It's given as an intramuscular injection, and this is part of the U.S. routine childhood vaccination schedule. Next, let's talk about hepatitis E. And the reason I'm jumping from hepatitis A to hepatitis E is because they cause very similar infections. So hepatitis E is a member of the Hep E virus family. It is a non-envelope virus. Its genome is positive sense single-stranded linear RNA, and it has an icosahedral capsid. Outbreaks of Hep E occur worldwide, usually in resource-limited areas. So just like hepatitis A, people get this infection from drinking fecal contaminated water. Also, just like hepatitis A, this is a self-limited acute infection and does not cause a chronic infection. You can diagnose hepatitis E by finding evidence of the Hep E virus genome in the serum or feces using PCR. You can also detect IgM antibodies to Hep E virus. And one unique feature of hepatitis E that makes it different from hepatitis A is the risk in pregnancy. For reasons that are not well understood, hepatic failure is more frequent during pregnancy, and there are reports of mortality rates as high as 15 to 25% among pregnant women when outbreaks of hepatitis E occurs. So the one thing you want to know about this virus for step one is that it's very dangerous during pregnancy. So moving on, now let's talk about hepatitis B. This is a member of the hepadnavirus family, and of all the viruses that cause viral hepatitis, this is the only one that is a DNA virus. It is an envelope virus with a circular genome, and it has an icosahedral capsid. And hepatitis B has three unique properties that you need to know about. The first unique property is that it has partially double-stranded DNA. Some of the genome is single-stranded. The way this genome replicates is it enters hepatocytes and goes to the nucleus. Once it gets into the nucleus, the DNA becomes fully double-stranded. At that point, it will synthesize RNA, and the RNA will go to the cytoplasm. Second unique feature is that this virus utilizes reverse transcriptase. You may think of reverse transcriptase as being an enzyme for HIV, and that's true, but it is also used by hepatitis B. The virus will make RNA and then use reverse transcriptase to convert that RNA into viral DNA, and then this viral DNA will get packaged into the capsid. And then the third unique feature is that the envelope for hepatitis B comes from the endoplasmic reticulum, which is a very unusual source. So here is a drawing to help you remember the way that hepatitis B virus replicates. It exists as partially double-stranded DNA, and it goes to the nucleus where it becomes double-stranded DNA. From there, mRNA is synthesized, which is used to create proteins. One of these proteins is reverse transcriptase, which will convert that mRNA back into partially double-stranded DNA, which can then be used to package into new virions that can go infect other cells. This is a drawing of the hepatitis B virus. It's called the Dane particle, named after the person who first characterized it. It's 42 nanometers in size, and it has an envelope on the outside which is coated with proteins called hepatitis B surface antigen. And these will be very important later when we talk about diagnosis of infection. On the inside, it has the capsid. Those are these red circles here, and the capsid contains proteins called hepatitis B core antigen, or HBC antigen. These will also be important later when we talk about diagnosis. There's another molecule associated with the capsid core called the hepatitis B E antigen, which is also important in diagnosis. You can see that the genome in the center is partially double-stranded and partially single-stranded, and it brings its own DNA polymerase with it, which will complete the double-stranding of the genome once the molecule gets into the nucleus. You can acquire hepatitis B through a number of different ways. First of all, you can get it through sexual contact. It is considered a sexually transmittable infection. You can also get it from IV exposure, so drug users who share needles can infect each other with hepatitis B. Rarely, a contaminated blood transfusion can cause a hepatitis B infection, and sometimes healthcare workers will have an accidental needle stick that will expose them to hepatitis B. It can also be passed from a pregnant woman to her fetus. This is especially true if the mother gets acute hepatitis B during the third trimester. Babies who are born with hepatitis B usually have minimal symptoms, even though there is lots of viral replication in the baby. This is because the baby has an immature immune system, so they can't mount a strong immune response, and therefore there are few of those symptoms of inflammation. Nevertheless, the babies are at very high risk of progression to chronic disease because of the immature immune system, and therefore there's lots of viral replication going on. It has an incubation period of 1 to 4 months after exposure, and there is a spectrum of clinical disease seen in patients with acute infection. 30% of patients will have what's called icteric hepatitis. This means they will have significant hepatitis and right upper quadrant pain, and they will be jaundiced. About 70% of patients have subclinical disease or mild hepatitis. This is often called anicteric. They're usually not jaundiced and their symptoms are less severe. Sometimes this is thought to be just a viral illness and it's not recognized as acute hepatitis B. No matter how the acute infection presents, it can go on to cause chronic hepatitis B, and the progression from acute to chronic disease depends heavily on age. So 90% of babies who are infected perinatally will develop chronic disease. Like I said before, they are the highest risk group. Children who get acute hepatitis B have about a 50% chance of developing chronic disease, and less than 5% of adults who get acute hepatitis B will develop chronic disease. Many chronic infections are asymptomatic, so many patients are what's called carriers of chronic hepatitis B. And if the hepatitis B is untreated, there is a risk of progression to cirrhosis, liver failure, hepatocellular carcinoma. The viral DNA can integrate into the host and cause cancer, and there's a risk of reactivation where people can get acute hepatitis many years after their initial acute hepatitis exposure. There is a phenomena called immune reconstitution. If HIV is treated without treating Hep B at the same time, it can lead to severe liver damage. So when the immune system reconstitutes itself from therapy for HIV, the symptoms of hepatitis B can become severe and the inflammation can damage the liver. So for this reason, people usually screen for hepatitis B before they start therapy with HIV drugs. There are two extrahepatic manifestations of hepatitis B that it's high yield to remember. The first one is called polyarteritis nodosa. I talk about this in the vasculitis module under the cardiology section. These patients have fever, fatigue, arthralgias. They often get abdominal pain and have melena in their stool. They will have neuropathy and they will have a rash. The second extrahepatic complication is glomerular disease. The most common presentation of glomerular disease in hepatitis B is a membranous nephropathy, and this presents as proteinuria and the nephrotic syndrome, and I talk about this in the modules on kidney disease. Now let's talk about the diagnosis of hepatitis B. There are two antigens that can be detected in the plasma of patients infected with hepatitis B. The first one is called the hepatitis B surface antigen, and the second one is called the hepatitis B E antigen. Then there are three antibodies that can be detected in the plasma of patients infected with Hep B. The first one is anti-hepatitis B surface antigen, which is the antibody to this antigen. The second one is anti-hepatitis B E antigen, which is the antibody to this antigen. And then the third one is anti-hepatitis B core antigen. Now, I didn't tell you about an antigen called hepatitis B core, and that's because this antigen cannot be detected in the plasma. We'll talk about why in a minute. But you can detect antibodies to that antigen, and that's part of the diagnosis of hepatitis B. The antigens rise in acute disease and then they fall as infection resolves, and the antibodies generally rise as the acute infection resolves. The hepatitis B surface antigen is the hallmark of hepatitis B infection. When it is elevated in the serum, it implies that the patient has either an acute or chronic infection. This is a glycoprotein that comes from the surface of the envelope, as the name implies. It comes from the surface of the virus, and it forms spheres and tubules when you look at it by electron microscopy. And you can detect the antigen weeks after exposure to the virus and even before the symptoms develop in patients who have acute hepatitis. When you recover from acute hepatitis, the Hep B surface antigens become undetectable in the plasma. This usually occurs about 4 to 6 months after exposure. If you convert from acute hepatitis B to a chronic infection, then the surface antigen will persist and be detectable in the blood for more than 6 months. If you've been infected in the past and recovered, or if you've been vaccinated, you will have the presence of antibodies to the surface antigen, but there won't be any antigens detectable, just the antibodies. And in general, when antibodies to the surface antigen rise, the surface antigen levels will start to fall and the infection begins to clear. You should know that the hepatitis B vaccine is a recombinant molecule of the surface antigen. So this is created by using culture techniques to take the genome for the surface antigen and make multiple copies of the protein. So you inject this into people to vaccinate them, and that means that vaccinated individuals will be positive for anti-Hep B surface antigen, but they will not have any presence of the surface antigen itself because they're not infected. They just have antibodies. All the other antibodies to other components of hepatitis B viruses, like the core and the E antigen, should all be negative because these people were never infected. They just had the protein for the surface antigen injected. Next, let's talk about the hepatitis B core antigen. This is an intracellular antigen. It comes from within hepatocytes that are infected. It's a capsid core protein and it's expressed on the surface of infected hepatocytes. But very importantly, it doesn't get into the plasma and it's not detectable in serum. You can only detect antibodies to the Hep B core antigen. You cannot detect the antigen itself. Anti-Hep B core antigen IgM rises in acute infection, and anti-Hep B core antigen IgG will be elevated in patients who have had a prior exposure or patients who have chronic infection. You need to be familiar with the window period. This is a brief period where the levels of hepatitis B surface antigen have fallen and are undetectable, but the levels of anti-Hep B surface antigen are not yet high enough to be detectable in the serum. This is called the window period, and it can give the false appearance of no infection. During this period, the sole marker of infection is anti-Hep B core antigen IgM, and that's why that core antigen is so important. Even though we cannot detect the antigen itself, we can detect the antibodies, and they are how you detect infection during the window period. The final hepatitis B antigen is called the E antigen. This is a viral protein that is secreted by infected cells and can be detected in the plasma. It's part of the capsid core, and the most important thing to know about the E antigen is that when it is detectable in the serum, it indicates significant viral replication. Elevated levels of the E antigen correlate very well with levels of hepatitis B virus DNA. So when the E antigen is elevated, it means there's lots of DNA and therefore lots of viruses being produced. This is different from hepatitis B surface antigen. When that is elevated in the plasma, it indicates the presence of the virus, but it doesn't correlate very well with significant replication. If you want to know whether the virus is replicating significantly, you need to look for presence of the E antigen. What this means for patients is that when the E antigen level is detectable, these patients are highly infectious. They are producing lots of virus inside their body. And when patients seroconvert and develop antibodies to the hepatitis B E antigen, this is usually associated with a fall in viral DNA production. You should also know that you can detect the levels of hepatitis B DNA in the plasma. This is detectable with PCR techniques. And the major role for detecting the DNA is for determining a viral load and deciding whether or not patients require treatment with drugs. So this is a classic graph that you can find in many textbooks and board review books, and it's a depiction of the rise and fall of the various serum markers of hepatitis B infection. So let's go through this carefully. So time 0 is when the patient is exposed to the virus, and you can see that about a month passes before anything is detectable in the serum. The first marker that begins to rise is the hepatitis B surface antigen, and note that it begins to rise during the incubation period before the patient has developed symptoms of acute illness. That level will rise and then fall if the patient clears the infection. The next marker to rise at about 2 months or so is hepatitis B E antigen, and then shortly after that you see levels of the hepatitis B core antigen antibody begin to rise. Sometime later, levels of the other antibodies begin to rise. This green line here is the anti-hepatitis B E antigen, and then this line here is the anti-hepatitis B surface antigen. Note that this right here is the window period. During this period, the levels of the hepatitis B surface antigen have fallen and are undetectable, but the levels of antibodies to hepatitis B surface antigen have not yet begun to rise. During this period, the levels of anti-hepatitis B core antigen are very high, and that's why this is the marker of infection during the window period. You may wonder why we don't look for anti-hepatitis B E antigen during the window period, and the reason is because, as you can see from this chart, the titer of that antibody is relatively low, and it is not a reliable marker of infection. The levels of anti-hepatitis B core antigen are much higher, and that's why they are the marker of infection during the window period. Also note that if a patient were to convert to chronic hepatitis B infection, then this red line would just continue out in this manner and would not fall down to the undetectable levels. So an important skill is to be able to interpret these blood tests. So let's go through some examples of that now. In a patient who has acute hepatitis B, they will have an elevated level of the hepatitis B surface antigen, except for during the window period. The IgM anti-hepatitis B core antibodies will be elevated even during the window period. Remember, this is the marker of infectivity during the window period. Hepatitis B E antigen will be elevated, and this will indicate that they are very infective and that they have lots of viral replication going on. And then you can also detect the DNA of the hepatitis B virus by PCR. In someone who has recovered after acute hepatitis, they will have antibodies to the hepatitis B surface antigen, antibodies to the E antigen, and antibodies to the core antigen as well. And these will all be IgG antibodies. They will have undetectable hepatitis B surface antigen. Remember, this is a marker of infection, so if they recover, that should go away. And then, of course, they will have absence of hepatitis B virus DNA. If patients have had a prior vaccination, they will be positive for the antibodies to hepatitis B surface antigen only. Remember that the vaccine is recombinant Hep B surface antigen, so they will have antibodies to this in their plasma. Importantly, though, they won't have any other antibodies present. No antibodies to the Hep B core and no antibodies to the Hep B E antigen. Chronically infected patients will have persistent positivity of the Hep B surface antigen. They will also have elevated levels of the Hep B E antigen if they have high infectivity and high degree of viral replication. They will be positive for antibodies to the hepatitis B core antigen, and then the viral DNA may be high or low depending on their viral load. And then two simple rules of thumb that have always helped me are that if the Hep B surface antigen is positive, then the patient is infected. It may be acute or chronic, but they are definitely infected. And if the Hep B surface antigen is negative, then the patient is not infected. And just by knowing these two, you can often narrow down the answer choices in a board question. There usually is no specific treatment for acute hepatitis B. Usually we just administer supportive care. Recall that I said that in immunocompetent adults, less than 5% will go on to develop chronic disease. So acute Hep B is usually only treated with antivirals in special circumstances like immunocompromise. There are multiple treatments available for chronic hepatitis B. Interferon, which is a cytokine, is sometimes administered. Lamivudine, which is a nucleoside reverse transcriptase, is sometimes administered. Recall that hepatitis B uses reverse transcriptase just like HIV, so this drug, which is usually thought of as an HIV drug, can also be used for hepatitis B. And I talk about the NRTI drugs in the module on HIV therapy. And then there are some other antiviral drugs that are sometimes administered. Our next cause of viral hepatitis is hepatitis C, and this is a member of the flavivirus family. Now, most of the members of the flavivirus family are mosquito illnesses. For example, yellow fever and dengue fever are caused by flaviviruses. Hepatitis C is a relatively unusual member of this family. It's an envelope virus, and its genome is positive sense single-stranded RNA that is linear with an icosahedral capsid. A very important thing to know about hepatitis C is that it has a high degree of antigenic variation. There are structures called enveloped glycoproteins on the surface of hepatitis C, and these glycoproteins contain a hypervariable region. This region is coded for by a portion of the Hep C genome that has a very high mutation rate. In addition, the RNA polymerase that hepatitis C makes lacks a proofreading function. The result is that there are frequent mutations in the portion of the genome that codes for these envelope glycoproteins, and the glycoproteins frequently change their structure. As a result, it's very difficult for the immune system to effectively eradicate hepatitis C, and this means that for patients there's a high rate of chronic infection. Remember that I told you that adults with acute hepatitis B have less than a 5% chance of developing chronic infection. For hepatitis C, the chance of developing chronic infection after acute exposure is greater than 50%. Most people who acquire hepatitis C acquire it through IV drug abuse if they share dirty needles or from a blood transfusion. And blood transfusion infections are very rare now because blood is screened for presence of the hepatitis C virus. There are also rare cases that have been reported from needle sticks by hospital workers or even some from sexual contact. Acute infection with hepatitis C is usually asymptomatic, and most people, as I said before, progress to develop chronic disease, and the disease is not diagnosed until it is picked up in the chronic phase. Chronic infection can be asymptomatic, and there also can be mild nonspecific symptoms like GI pain or right upper quadrant pain. Often chronic infection is incidentally discovered when someone checks liver function tests for some reason, and there is screening for hepatitis C done in high-risk patients like those who abuse IV drugs. You can diagnose hepatitis C by looking for hepatitis C viral RNA by PCR. The levels of hepatitis C virus RNA become elevated soon after exposure. And then there are antibodies to the hepatitis C virus, and these become elevated by about 12 weeks after exposure. And in people who have chronic disease, which as I said before is common, both of these will be elevated. If you have a chronic infection with hepatitis C, there's a risk of progression to cirrhosis of the liver and liver failure. Hepatitis C is a common indication for a liver transplant. There's also a risk of progression to hepatocellular carcinoma. There are a number of treatment options. Two of the more commonly used drugs are interferon, which is a cytokine, and ribavirin, which is an antiviral medication, and there are other antiviral drugs sometimes used. And I talk about both of these treatments in the module on antiviral drugs. Our final cause of viral hepatitis is hepatitis D, which is also called the delta agent. This is a very small virus. It's enveloped. It has a negative sense RNA genome that is circular. It's called a defective virus because it lacks genes for its envelope proteins, so it uses the hepatitis B surface antigen for its envelope protein. This means that it can only infect cells that are already infected with hepatitis B. It is a co-infector of cells infected by hepatitis B. Its genome encodes for just one protein, that's for the delta antigen called HDAG, and the virus particles will carry this HDAG antigen. So the pathogenesis of hepatitis D infection is that it invades hepatocytes and then travels to the nucleus. Once it gets inside the nucleus, it uses the hepatitis B virus to provide the envelope, so it has to be a co-infected cell. The virus particles of hepatitis D then get coated with the Hep B surface antigen, and then hepatitis D uses host cell RNA polymerases to replicate its genome. You can't contract a hepatitis D infection at the same time you're infected with hepatitis B. You can get co-infected by both viruses at the same time. You also can get a hepatitis D virus superinfection on top of a chronic hepatitis B infection. And patients who get a superinfection often get a flare of their hepatitis. So a scenario to know about for board questions is someone who has chronic hepatitis B and then gets a flare of acute hepatitis. This may represent a superinfection with hepatitis D. You can diagnose this by finding the hepatitis D antigen in the serum, or by finding RNA to hepatitis D, or by finding antibodies. And one important thing to recognize is if you vaccinate someone against hepatitis B, you are de facto vaccinating them against hepatitis D, because they'll never get this infection if they don't get Hep B. The treatment of hepatitis D is very complex, it's difficult to treat, and it's not something you really need to know about for step 1. And that concludes our module on viral hepatitis.